as our presenter. He is going to speak on the initiation of medication-assisted therapy in the emergency department, and it's the case for ED-MAT, so it's going to be a very informative discussion today. Dr. Avani graduated from the University of Michigan Medical School in 2000 and completed his residency training in emergency medicine at Maine Medical Center in 2003. Since 2009, he's worked clinically at Midcoast Hospital and is a founding partner of Blue Water Emergency Partners, a private democratic emergency medicine partnership based in Maine. He's the medical director of the Midcoast Hospital Emergency Department and leads a team of 15 physicians, 11 APPs, and I'm unsure of APPs, advanced practice providers. Is that right? Good, thank you. And 2 fellows as well. And he's currently the president of the medical staff at Midcoast, and his special areas of interest include medical error and cognitive bias, tribalism in medicine, provider resilience, and of course, substance use disorder. So let me turn it over to Dr. Avani. Welcome, thank you.
Great, thanks a lot. Can you hear me okay?
Yes, we can.
Okay, good. So thanks for having me today. I'm going to talk to you about emergency department initiated medication-assisted therapy. This is something that we've been doing at Midcoast Hospital for about 1.5 years and have been talking about it to people for 2 years or more. And it's something that I feel lucky to have been a part of at Midcoast, and I've really developed a passion for bringing this work elsewhere. And so I really appreciate the opportunity to participate in this session. And then we're also going to be starting a new ECHO session with Project Rise through Maine Quality Counts as well, coming up pretty soon. So we can go to the next slide. So I'm just going to give a little bit of background of where we've been, talk about the study that came out of Yale that really started this for most emergency departments, including ours. A little bit about our process and our results, but a little bit even more about just the reflections that we've had as we've learned about this. So next slide. So the first slide I wanted to show you is, if you haven't seen this already, this is a 1980 New England Journal of Medicine letter that you can see is only several lines long. And this was a study that came out of Boston University with about 40,000 hospitalized patients who were given opiates for pain while in the hospital. These patients actually did not get pain medicines to go home with. As back in the 60s, 70s, when this study was done, there was pretty rigorous control of opiates going out of the hospital into the home. But you can see the last 3 lines. We conclude that despite widespread use of narcotic drugs in hospital, the development of addiction is rare in medical patients with no history of addiction. And this letter really set off in motion a change in the way we were educating physicians. And I can distinctly remember in my residency in the early 2000s being taught that if used for a legitimate pain complaint, that the risk of addiction was very rare. This study, the graph at the bottom is the number of times this study's been cited. And again, this is really just a letter. It's not even a peer-reviewed article. But the letter was cited over 600 times since it was publicized in the New England Journal. And they compared that to, compared to about 11 times that letters like this would have been cited in other literature going forward. And I include this not necessarily as an excuse to why we are where we are, but to an acknowledgement of the medical community was certainly a part of the problem, and that we need to contribute to the solution. If you want to read more about this, the story of this is recounted in the book Dreamland by Sam Quinones, if you haven't read that already. So next slide. So what are we going to do about it? Clearly, right now, their evidence and the predominant thinking is that medication-assisted therapy is effective. And in fact, this study that came out of Baltimore, as they followed the introduction of methadone clinics and then buprenorphine into the city, showed that deaths from heroin went down. Next slide. This study is actually even more chilling, and this is a study that came out of Sweden that took 2 groups of people. It was a small study. There's only 40 people in each group, but they looked at long-term maintenance with the red dots, and buprenorphine for up to a year versus a 6-day taper of buprenorphine, and then abstinence therapy. And in the buprenorphine group, about 75% of the group remained in maintenance and in treatment. And in the control group, who were on abstinence therapy, 0% were in therapy. And the most chilling part of this is that 20% of that controlled group was actually dead at a year. And there really are very few interventions in medicine that have that kind of success. And really what these two studies emphasize is just looking at buprenorphine and methadone as a harm reduction, that you can actually save lives just by doing this. So next slide. So the next thing that commonly comes up is, well, aren't we just doing substitution therapy? Aren't we substituting one addiction for another? And really the answer to that is no. This should be looked at as a tool that helps patients engage in other aspects of their life and in treatment. And, buprenorphine does not cause a high if a patient is already opioid dependent. Next slide. And really looking at beyond a harm reduction framework, looking at addiction as a chronic disease that has similar rates of relapse to other chronic diseases like diabetes, hypertension, and asthma. And what we've seen, and what I hope we continue to see in the medical community, is an evolution of thought from simple harm reduction to looking at addiction as a true disease. Next slide. And then the next one as well. So just a little bit about where we are. I'm based at Midcoast Hospital. I'm the director of a 31,000 volume emergency department, which for Maine puts us at about a medium-sized hospital, but nationwide is still relatively small. We have an addiction resource center right across town, not in the same building, but one based in Brunswick and Damariscotta. And they've always had an emphasis on rapid access in their program. This has been relatively easy for us to set up at Brunswick because we have these two groups that were already there in existence, and what we really had to do was bring the two together. And in fact, the first title that we used for this talk was Breaking Down Silos. So next slide. At our emergency department, just like any other emergency department across the country, we see the prevalence of substance use disorders increasing, including the opioid epidemic. And what in several years ago at the same time seemed to be a decrease in the resources that were available upstream and downstream from the ED. I think that we've actually seen a change in that, in increased programming, increased access, as we've been talking about this for the last 2-3 years. Next slide. So, and the next one as well. So in 2015, a group from Yale published a study that looked at 3 groups in their emergency department with opioid use disorder. And the groups were randomized to traditional referral, which would mean basically getting a phone number when they're in the ED, a brief intervention interview, and then the same referral, and then emergency department initiated buprenorphine with a warm handoff and a soft landing at the treatment facility. And the outcomes they looked at were how many people were engaged in treatment at 30 days. Next slide. And so you can see that roughly twice as many people, or almost 80% of the people in the buprenorphine group, were engaged in therapy at 30 days versus 37 and 45% in the control groups. Next slide. Now, one of the things they also looked at as a secondary outcome was self-reported days of use per week. And so you can see that the buprenorphine group, in terms of self-report, did not achieve complete abstinence, but the self-reported days of use was about half, or a little bit more than half. Some people tend to look at this as a failure of the study, that we did not achieve 100% abstinence. But I think, really what we're trying to achieve from just a simple harm reduction model and the disease model, if we understand this disease in this way, is that engagement in therapy is really what we're looking for. And so I still look at this study as quite a positive result. Next slide. So in terms of the process we met as a group from the emergency department, a group from our addiction resource center, a group from our colleagues of Maine Behavioral Healthcare, really with the goals of just defining standardized screening, standardized pathways, and standardized communication to initiate buprenorphine in the right patients in the EDAR with what we call a warm handoff and a soft landing. There's a phone call involved to the Addiction Resource Center. The patient leaves not only after receiving the first of the dose of their meds, but they leave with a date and a time that they're going to be seen, and often it's the next business day or in 24 hours or 48 hours. Next slide. So the results that we've seen, and I haven't updated this in a little bit, but in the first 15 months, we started buprenorphine on about 37 patients. And what we saw was the uptake was generally pretty slow. It was spotty here and there. And we've seen now gotten to about a steady state of about 5 or 6 patients a month, or about 1 or 2 a week. So numbers are not huge, but really, when you think about what we do in an emergency department, we intervene on high acuity but very low frequency events. Most of what we do is not life-threatening. Similar numbers when we look at programs that we've started to take care of stroke patients, and we give these thrombolytic clot-busting drugs. We have spent tremendous amount of effort putting in programs to set those programs up and connect with our stroke centers. And last year we gave those medicines 15 times to people. So the numbers are low in that, but even higher in this group. I think while we talk about the numbers and data, sometimes I think it's important to tell some stories, because we can just look at numbers and graphs and look at patients, and 37 patients is kind of abstract. But one of the patients that we first started in the program was a 23-year-old woman who was pregnant 3 months. She was using heroin daily. She had a 3-year-old at home, and she was a frequent visitor to the emergency department. And since she's been engaged in therapy, she had her child. She's successfully parenting 2 children, holding down a job, and really engaging in therapy, and really illustrates that this is much more of an impact beyond the one patient, and that we're affecting the lives of families as mothers, daughters, sons, and coworkers. Next slide. And the next thing, in terms of the results, we track these patients, and I've been really happy to see that most of our patients actually do show up at their intake appointment. One of the concerns in some circles when we start programs like this is that people are going to come to the emergency department to get a dose of buprenorphine but aren't going to engage in therapy. And we've seen that almost all of our patients actually show up to their intake appointment. And then next slide. And that about 70% remain in treatment at ARC at 30 days, which is quite good numbers. And actually some people have been moved on to other programs, such as methadone programs or long-term residential programs. And so our retention is probably even better than that. Next slide. As you may have seen, we've been featured in a lot of media coverage, and this is generating a lot of interest in the state. And next slide as well. And as we've seen that as the new administration has taken hold and Gordon is in place as the opioid commissioner for the governor, the future looks much brighter than it was not too long ago. And among the 10-point plan that Governor Mills has initiated at the beginning of the administration includes MAT initiation in every emergency department and recovery coaches in every emergency department as well. Next slide. So we've been given the opportunity to speak about what we're doing at Maine Medical Association, New Hampshire Medical Association through these forms of Maine Quality Counts. We've reached out to many EDs, and now we start this new project of Project Rise, where we're going to be doing formal education to emergency departments who are either contemplating or starting their programs in their emergency department. Next slide. So reflections on this, really these programs are pretty simple. You need 2 things. You need an emergency department who's engaged and willing to participate in this kind of programming, And you really need a treatment center that's going to partner with the emergency department. And I think that's one of the biggest things that we try to emphasize as we go around and talk about this. The emergency department can't do this on their own. The emergency department is a place to stabilize an acute medical condition, but then refer on to who can do definitive care and long-term care, and the emergency department just can't do that. And so I think you'll see that your emergency departments will engage with doing this as long as they know that there is a treatment center willing to get rapid access to them and simplify the process. The way that we do it, we screen patients, we give a dose of buprenorphine, we call ARC, and it's, basically sounds good. They can see us tomorrow at 9 o'clock. And there's a back and forth, and it really works because it's simple and the expectations on both sides are the same. Next slide. So I want to spend a little bit of time just reflecting on what we've learned from this. Go to the next slide. One of the things that's going to be a big concern for many emergency departments is that once they start programs like this, that they'll be flooded with patients. We have really not seen that to be the case in our emergency department, as evidenced by our numbers, and nor have any of the EDs around the state that are doing this, or in Boston at Mass General or any other places. I think it's one of the things that really is, you only can prove that until you do it. But you really have to take this into the context of most emergency departments around the state and the country are currently overcrowded with patients who are boarding, waiting for admissions, and it is more work in an emergency department to do this. And so there's a little bit of hesitancy to take on more work, especially if there's not a downstream outlet for them. But we've seen if you can set the program up, that people are much more willing to engage with that. Next slide. The concept of doing this in the emergency department is based on essentially an opportunity to intervene. Patients with an opioid use disorder, if they find themselves wanting treatment and wanting therapy and wanting help, we need to be able as a medical community to provide that therapy almost instantaneously, because if we don't seize on that opportunity to intervene, that opportunity may not present itself again. Even worse is if patients come and ask for help and we're really not able to give it, or we meet the patients with an adversarial relationship, that opportunity really may not come again. And we know that in many patients, they may actually die before we're able to intervene again. The ER is open 24 hours a day, 7 days a week, and it's particularly well positioned to be the access point for patients to meet them when they're ready. Next slide. Even if patients don't take us up on the program, it gives us an opportunity to plant a seed in someone's mind. And so if someone comes in after an overdose, or someone comes in with a medical complication of their use, we're able to let them know that even if they're not ready at the time that they're with us then, that we're always there and we have an open door. In fact, we had an overdose patient who came in after receiving Narcan in the field, was offered the program, declined, and actually came back a week later and had thought about it and changed his mind. We've seen that most patients after an overdose are not interested in treatment at the time. And one of the things that we'd like to work on is trying to figure out a framework and a way to motivate those patients for change at the time of those kinds of events. Next slide. The other thing, again, as a reflection that we're trying to encourage is for people in the medical community, and particularly in the emergency department, to think about this as an emergency medical condition. Again, what we do in most cases, the really sick patients are low volume but high impact, and this is a similar kind of event where this is going to be low volume for most emergency departments but huge impact. And looking at outcomes, we've looked at studies that have shown that after a non-fatal overdose, that mortality rates in those patients are up to 8 or 10% in 1 year. And so it really compares a lot with a lot of the other emergency medical conditions that we look at. Next slide. The other concept is, in medicine, we are creating pit crews. And if there's an article published in the New Yorker by Atul Gawande called Cowboys and Pit Crews from 2011. If you haven't read this, it's a good read about where medicine has been and where we're going. It used to be that doctors and the doctors could sort of hang a shingle and do everything for everybody. And as we've seen medicine get increasingly complex, what we're now needing to create are pit crews of doctors, each of whom have a defined role that's standardized, and so that we can work more efficiently with each other. And this has been a great experience for us, creating the pit crew that's helping this patient population. And click one more time. So the next idea is that most of us, including emergency providers, like to have problems that they have a tool to solve. The prior paradigm in most emergency departments was that when someone came in asking for help for an opioid use disorder, most of the time what we could provide them was a phone number and maybe a handshake. And in a lot of ways, those were frustrating encounters, not only for the patients, but for the providers who were in those visits. And one of the concepts I think that we've seen is that my argument is that a lot of the stigma and bias that comes from the healthcare community towards patients in the ER may stem from our own feeling of impotence with this problem, and that if we've given people a tool, they are going to be much more likely to engage with the problem, and also much more likely to just sit down with a patient and create collaboration, and as opposed to the traditional adversarial relationship. And so next slide. The reason that we're able to more or less roll out the welcome mat for these patients is because we've given our providers a tool to allow them to engage with the patients. We had a patient who came in not long ago that one of my partners saw, and he had an abscess in his arm from injecting, and his abscess was treated. He was offered our program, but he declined. He said, I'm just not really ready. And he came back a week later, and I saw him at that time just have his wound checked, and I offered him the program again. And he again declined because he really wasn't ready. But he said to me, I got to tell you, you guys are so cool. He said, you guys talk to me like I'm a real person. And the last time I went to the dentist and told them that I was using, they basically just stopped talking to me. And one of the really cool things that we've seen is that truly has permeated through our department, and our providers now feel much more engaged with this patient population and much more able to sit down with them, have a conversation, and collaborate versus the traditional adversarial relationship. And so next slide. And so while this has been a huge win for the patients, I think it's been also a huge win for our providers as well. We've actually really seen truly attitudes in the healthcare community change and evolved from looking at this from harm reduction and now really embracing the disease model of this problem. When we started talking about this over 2 years ago at one of our emergency department forums with several directors, I think people thought we were crazy for thinking about doing this. But as we've seen over the last couple of years, I think more and more emergency departments are doing this. We have probably about 6 or 8 EDs in the state that are currently doing this, and several more who are starting, and we're going to be helping get them up and running pretty soon. So next slide. So the future, what we're hoping for is for every emergency department to be initiating medication-assisted therapy, that every emergency department is distributing Narcan. One of the things that we'd like to tap into is increasing presence of peer support in the emergency department. And one of the last things that we're still trying to work on figuring out the keys to is how do we motivate people towards treatment when they've recently had an overdose. And also I'll end with just a quick quote from the Annals of Internal Medicine in 2018. The great part of the tragedy of this opioid crisis is that unlike in previous such crises America's seen, we now possess effective treatment strategies that could address it and save many lives Yet tens of thousands of people die each year because they have not received these treatments. Ending the crisis will require changing policies to make these medications more accessible and educating primary care and emergency providers, among others, that opioid addiction is a medical illness that must be treated aggressively with the effective tools that are available. That's about it.
Thank you, Dr. Ivani. That was very powerful indeed, and a lot of work over the last 2 years. Just incredible. It's just very humbling.